Thank you for the presentation, Dr. Hoppan. I'm not going to say that it will be spontaneously resolved anyway. So just this is truly what I'm doing. So I'm not operating in the first year at all. Can you be starting the next? Yeah. So can you start with that? Yeah. So it is definitely a controversy, no doubt, and we started our career. Actually, I started my career doing it as an emergency. We have to do it once we see them. It is actually an emergency for us to save binocularity, keep them again aligned. And I started my work and my career 20 something years ago doing that. So I'm not saying that this is wrong or something like that. No, of course not. And definitely some people will say, make it delayed now for till the age of 4. So it's a big, how can I, isn't it? Okay, so it's not that one. So again, the criteria you all know about the big angle and the cross fixation, which is one of the points which is protecting somehow from lazy eye. So the stress of having a dropped vision is not there, you know that. So it's all about binocularity only. And now you have association, which was not mentioned. The issue of association is a point which is very important that we have inferior oblique overaction association, we have DVD, we have nystagmus, and this will be considered in the surgery or no? Yes, but are you going to assess properly? And we have also the refractive error. And we didn't also mention that we have early onset esotropia. The change in the name of infantile esotropia to early onset esotropia is coming from having error refraction, sometimes more than +2. And at that time, sometimes some of them, and you know in your practice, you are correcting them with glasses and they are corrected. So you will know the accommodative element in the early onset esotropia. Sometimes glasses only can fix that. So you have to exclude this from the surgical correction in the first year. So refractive errors also are there. The associating sensory conditions, which is there, like the amblyopia, is not likely because of the cross fixation. But the very low or absence stereopsis is totally agreed. We know, and the depth of perception and the totally missed up retinal corresponding points is definitely a stress on us in the first year. We are thinking about them. Definitely. We know that this is a very valid point for those people operating in the first year, but why we are not saying that it is not that much convenient. Definitely, you have a very uncooperative patient. You have a bad mood, high temper patient. You know that all of the infantile esotropia, they are like that. And you are having difficulties measuring the angle in the first year. And you have also very difficult assessment of the associated inferior oblique or patterns or nystagmus with definitely small eyes with very thin sclera, which is giving you a stress in correcting those during surgery. And the aim of saving binocularity, which was mentioned by my colleague, of course, is definitely going to make you reach better stereopsis if you will correct early. But you are going to reach a fovea-parafoveal fixation. It is a monofixation syndrome, right? So whatever you are going to fix early or late, you are going to reach a monofixation syndrome. You are not going to reach a foveal-foveal fusion. So the retinal corresponding points, the ideal is not going to be reached even if you are going to operate in the first year. And what you are going to get if with some delay, you are going to re-refract, you are going to see the fundus examination properly, so no surprises. You are going to get better angle of deviation measurements, and you are going to get the hidden obliques, so you will decrease the possibility of a second step. You are going definitely to exclude any DVDs and include it in the first step. And it is definitely more easy to convince the parents, the anesthesiologist. You will get, because most of them, by the way, are premature, you know, and they will be better in the weight, and they will be better if they have any associated congenital anomalies. You are excluding many of this. You are going to get a proper pre-anesthesia testing, you are going to get much better, or definitely more thick sclera, less complication of the surgery, and you are going to get, if they have any congenital anomalies associated, which is possible, they are going to be excluded. So you are going to gain a lot. For early intervention, you are going to definitely retain early binocularity, and you get a very high percentage of a higher step, a second step. So the point which is raised by my colleague, that you are going to get binocularity early, and you will say, I am a very good pediatric ophthalmologist, I will get the inferior oblique early, I will measure the angle properly, I'm having a very good team, I am working in a very good facility, but is this kid going to keep the alignment? This is the point which I am facing, and shifted me totally to work in the second year ongoing. Why? Because even if I will get a very aligned kid after the surgery, very successful one, I got the obliques done, I got my DVD everything done, I am not having an sorry, can you turn by start back? Yeah, I'm getting, after a year from fixing them, whether consecutive exotropia and or residual esotropia, the esotropia will be so back, or I will have a consecutive exotropia. I want your experience about that. I'm sure that many of you are putting, and in literature it is more than 30% of the patients, they are put back into surgery again because of whether residual or again exotropia, consecutive exotropia, because the kid cannot maintain, the small ones, they cannot maintain the alignment, they are not properly keeping themselves in the horometer with the corresponding points, proper corresponding points. But when you are giving yourself a late intervention, this will make you definitely have less possible second intervention, definitely more accurate measures, definitely complete diagnosis for the association, less surgical complication, better tolerance to the surgery as well from all. And the sensory outcome, surprisingly, monofixation syndrome as well. You will have the same binocularity if you will measure, no differences in the monocularity, which is the same. And we are getting, again, I'm losing the slide. And you are going to have a more capable kid to maintain the alignment and be gaining a binocularity intact forever, supposedly. And this is, the literature is saying everything, unfortunately. You will have someone who is back supporting the every idea. And the best, in my opinion, is between 12 to 18. You will get months of age. This is what I'm doing now. I'm doing it in the second year, not in the first year, something between 18 to 12 to 24, and it's giving the best results actually, maintaining binocularity, maintaining alignment, getting the best of binocularity. One bullet will get it all. In one shot, you will get it all. You will not be in need of a second step, much less percentage. Instead of 30% second step in infantile esotropia, you will get it all, and you will not follow the emotions. Because emotionally, I will not be happy to send a squint patient who I know that I'm supposed to do surgery for home, but I'm not going to put him back, and I know that very high possibility that I'm going to operate upon him again. I will just delay it for a few months and do it once and forever. Thank you very much.